Hello and welcome. My name is Fatima Cardoso. I'm a medical oncologist. I'm also the president of the Advanced Breast Cancer Global Alliance and the Advanced Breast Cancer International Consensus Guidelines. I am now based in Nice, France, at the Center Antoine Lacassagne. And it's a real pleasure, and I thank you for the invitation to be here to speak with all of you, the patient advocates and patients, about the work of the Advanced Breast Cancer Global Alliance. I hope to show you how patient advocacy, working together with all the stakeholders, with healthcare professionals, with policymakers, with everyone involved, can really lead to a change in breast cancer care. So I will briefly discuss with you the findings of a very important report that we have published recently that we call the Advanced Breast Cancer Global Decade Report 2015-2025. So these are my disclosures. And just do a little bit of introduction. So you are all very much aware for sure about the numbers of breast cancer. So you see that in 2022, there were 2.3 million new cases per year, and the incidence is expected to continue to rise. So in 2045, there will be about 3.36 million new cases per year. Fortunately, the percentage of mortality of early breast cancer has been improving. However, the same, and as you can see here in this graphic, from the 90s, we see a very substantial drop in mortality in all high-income countries. And this is despite the increased incidence. And why? Because we start doing screening and early detection. We start also talking and educating women about it for early detection, but we also develop new treatments such as chemotherapy, endocrine therapy, and this has led altogether to a change in mortality. However, when you look at what happened in metastatic or advanced breast cancer, you see that the improvements until 2015 had been very, very, very slow. So from the 90s to the 2000s, we just improved about 2% in terms of percentage of patients alive at 5 years. And you see in the bottom graphic that the curves are almost overlapping. So for a long time, the median survival, the average time a person would be alive after diagnosis of metastasis remain between 2 and 3 years. Now, we wanted to change that, and that's the genesis of the creation of the ABC Global Alliance. And when we look at early breast cancer and then try to understand what had really changed the mortality, we saw that the fact that patients started to be treated according to evidence-based, so according to guidelines, high-quality guidelines, and in a multidisciplinary team, that has led to improvements in survival. So we now know that treating according to high-quality guidelines by a specialized, dedicated, multidisciplinary team improves survival. And this is true for early, but also for metastatic breast cancer. And that's why we started our work by creating high-quality guidelines. And you know that there are many guidelines. So why are the ABC guidelines special? Because patients are really involved in the creation of the guidelines. The guidelines are truly patient-centered. Patients are part of the consensus panel, so they have a voice for the guidelines. It's a truly global effort with people from all over the world. They are very practical, and they can either be adopted or adapted in all countries. So from the guidelines then came the creation of the Alliance, and the Alliance is like a federation. So our members are organizations, and now we have more than 300 members in more than 120 countries around the world. And the goal is to work together, to collaborate, to share our resources and knowledge. So one of the things we have done at the creation of the alliance was to do a global report looking at what had happened in the field of breast cancer from 2005 to 2015. And based on the findings of that report that was also published in the journal The Breast, we have defined 10 goals, 10 goals, 10 objectives for this decade, 2015-2025. And these are these goals. They were defined together with patients and all the other stakeholders, and they cover many of the needs of a patient. So of course, we wanted goal number 1, improve survival, also improve quality of life, but also collect high quality data and find out how many patients are living with this disease. Fight for multidisciplinary care, as I explained to you how important it is. Improve communication, improve information dedicated to metastatic breast cancer. Also improve access to supportive and palliative care. Fight the stigma and isolation, and fight for a better and equitable access to high quality care, and also help patients who wish to do so to continue to work with proper conditions. So that was for the decade until 2025. So at the end of the decade, at the end of last year, we have presented our report, what happened for each of these goals and in the decade of 2015 to 2025. So this was a 2-year work that involved a very large group of experts, 47 experts from patients, advocates, physicians, nurses, pharma, policymakers, all of those who wanted to be involved. And you can find all the details of the report, either scanning this QR code and you go straight to the report, or you can also have free access in a special issue of The Breast that has summaries for each of the goals. So I hope you will take the time to go into the details. I will briefly show you now what were the improvements and what is still needs to be done. If I want to summarize the entire report, I can tell you that we have seen advances for all the goals except one, and that is accessibility. So unfortunately, inequities have become even worse in this decade, and I'll come back to that. So what about goal number 1, which is survival? So I showed you that between 2005 and 15, there were only 2% improvement. In this last decade, there was a bit better, still small, from 26 to 33% percentage of patients alive at 5 years, but a better improvement. We have now new targeted therapies for 2 of the 3 subtypes of breast cancer, so the called HER2 positive and also the hormonal dependent. And for those, we can reach a median survival that it's over 5 years. And we now have excellent guidelines, the ABC guidelines and others that can be applied in clinical practice. However, the survival has not improved equally for all patients. For example, for triple negative, there was no improvement. We still remain at 13 months. What we see in clinical trials doesn't always happen in clinical practice, in real life, particularly for more complex populations like elderly patients, ethnic minorities, those who live in rural area, for example. And access is very, very unequal, and I will come back to that. So this is the graphic updated with this last decade, where you see a better improvement, although still slowly. And here you can see in this graphic from a new real-world study, what you can see in the green and red and dark blue curves, you see an improvement of the survival. And these are the HER2 positives and the hormonal receptor positive breast cancer. And in the light blue, you see the triple negative where there was almost no improvement in real life. Now moving to goal number 2, collection of data. And I'll come back why is it so important. But currently, we still do not know what is the true number of people living with metastatic breast cancer. And this has to do with the fact that cancer registers register diagnosis and death. They do not register relapse. But we have improved in this decade. We start having new methodology to bring data together and have better estimates of how many people are living with this disease. We still have a long way to go to solve this problem. I told you that we have about 2.3 new breast cancer cases per year. That leads to about 700,000 deaths per year, but we don't know how many are living with metastatic disease. We know something called prevalence, which means patients who had a diagnosis in the last 5 years and are still alive, but that includes all the survivors as well as the metastatic cancer patients. Some countries have gone through the big effort of having national registries focusing on metastatic disease, but the cancer registers are still have not solved the problem. Why is this important? I'll give you the example of Australia that has had a major step forward. I'm not going to complicate very much this. This is really available online. I can just say that using a lot of methodology, now they have a first estimate closer to reality of how many people live with this disease. And you can see that they found out that almost 21,000 people are living with this disease. And they had previously, with the estimates before, thought that there were only 11,000, 10,500. So the estimates that we have are very poor, and there are many more people living with this disease than we thought. And so they need a lot of resources, and we need to do a lot of national efforts, and particularly in Korea as well, because we don't know how many patients are living with metastatic disease. But that also shows this example in Australia. This was led by patient advocates. So if this shows how if patient advocates work together with governments, with researchers, with cancer registers, healthcare professionals, we can solve this problem. Now, moving on to the other goals, what about quality of life? Well, we have seen that we have new treatments that led to a lower use of chemotherapy and therefore improvement of quality of life. However, the target therapies are not without side effects, and we have treatments that have new side effects for which we need to learn how to manage. We also measure quality of life very badly because we don't have a specific tool. And now it has been developed. It is not yet finalized, but it's in late stages of development, the first specific tool to measure quality of life in the metastatic setting. We also speak and implement in clinical trials, less in clinical practice, what we call patient-reported outcomes. So making the patient report the side effects and making it much better. However, when we look at the research, we see that almost 80% of patients say that the disease has a negative impact in their emotional and psychological well-being. We also see that in clinical practice, less than half of the physicians evaluate quality of life. And that when we look at presentation of new studies, people refer to the severe side effects, and they forget that even if it's not severe, if you have a constant side effect, a persistent side effect, that can also affect your quality of life. This is a part of the research of the report, and what you see in green is the negative impact in the different areas of life: physical functioning, emotional, psychological well-being, ability to perform your normal tasks and responsibilities, cognitive function. They all have a very high negative impact. And perhaps what is very interesting to see is that the disease did not impact negatively so frequently the relationships. Now, in terms of multidisciplinary care, what we see is that we are talking more and more about multidisciplinary care for metastatic disease, and we have been trying to implement tumor boards for metastatic disease. However, this is still very unequal. It happens in very specialized centers, but not everywhere. And not always we have all the disciplines like palliative care, nutrition, physiotherapy. They are not always present in the tumor boards where they are so important. And so a lot more is needed for this goal. In terms of communication, we have achieved quite a lot. And now most physicians are being trained to communicate better with patients. The communication skills are included in our curriculum, so they are mandatory to be learned, but we still think there's still a disconnect between what the physician believes that he or she has communicated and what the patient experiences. So the patient still experience very often not so good communication. And as you can see there, less than half of the patients think that the physician or felt that the physician addressed their emotional and psychosocial needs. And also we can see for the treatment decision-making, all the factors that were ranked, they were ranked differently from patients on your left and physicians on your right, or healthcare professionals on your right. For example, physicians always scored very low the social impact, the cost of treatment, and the treatment logistics, but this was scored much higher for the patients. What is interesting is that the three major factors were scored high for both efficacy, quality of life, and adverse events. So those were the three first for both, but the others are not giving the same weight for patients or for healthcare professionals. In terms of information, we have seen in this last decade really a substantial improvement of dedicated information for metastatic breast cancer. And the patient groups, the patient advocacy groups have done an excellent job. However, we still see that the individual patient, the patient that is not linked to a patient advocacy group, they still have some difficulty accessing this information. Almost all the information is digital, so those that are the older patients, those that cannot access the digital information, have bigger difficulties. And also what we see in the research is that the information focus a lot on treatment, the symptoms, the side effects, but they forget other points that are very important for patients, like rights for work, for example, social rights, financial support. These are very important as well and not so often given information about. In terms of supportive services, we have also had some improvement. Palliative care is now recommended in most of the national cancer control plans. However, when we look at the clinical practice, then we have a huge difficulty in implementation. And we see that just about half of the patients were never even offered supportive services. When we call supportive services, these are psychosocial support, psychological support, also supportive measures, treatment of the side effects, and as well as palliative care. And we still see that palliative care is introduced very late, sometimes also because patients are afraid of palliative care. But palliative care should be going hand in hand with oncological care. And we see also that these supportive services are very often out of pocket. Even in rich countries, high-income countries like Korea, very often the patient has to pay at least part of these services. And when you look at the research, you see that access to palliative care depends if you are being treated in a high-income country or a low-income country, if you are being treated in a hospital that has oncology department or in a hospital without oncology department. And here is the research showing, and what you see in light blue, this very high percentage of patients who were never offered palliative care services. So this is, and you see that it's in many different countries. So this is quite scary. In terms of stigma and isolation, also an improvement in terms of speaking more openly about metastatic breast cancer. However, we still have about half of the patients that feel that they are not understood, they feel isolated, so they still suffer the stigma. And what we see also is misinformation, misconceptions. You have all heard about fake news, and we have lots of wrong information about metastatic breast cancer, including this terrible misconception saying, oh, it's pointless, so there's no use to treat this disease because it's incurable anyway. And here you see wrong messages about metastatic breast cancer that patients said they already heard, they were told about this. And you see that all of them, these are not correct messages, these are wrong, but still the public and sometimes even some healthcare professionals and decision makers believe in some of these wrong statements. So that leads to isolation. And you see here high percentages of people living with metastatic breast cancer that feel that they are not understood and that people around them do not understand the disease. However, something very interesting, part of our research was social listening. So listening online what people with this disease were talking about. And it's not without surprise that a lot of the conversations were about sadness and fear, but look, almost the same percentage about joy. So it is still possible to turn around this experience with this disease into something positive. Now, speaking about goal number 9 and access to care. This, as I told you, was the goal where we have seen some improvements. There are some improvements on access to essential medicines. There are also some projects ongoing to improve accessibility of treatments in low middle income countries, including radiation. But we have seen that the inequities have increased, not just between low middle income countries and high income countries, but inside each of the high income countries. So inside each country, a patient has access to different treatments according to their coverage or their ability to pay. And this happens in rich countries like the US and for sure also in Korea. And what we also see is what I briefly mentioned, that this out of pocket, so expenses that the patient has to pay, it is increasing and goes up to 60% that the patient has to pay. And this has to do with these curves. You see here the cost of treating metastatic breast cancer over time. It's increasing rapidly. And you see 2 curves below. The blue curve are the cost of direct treatment, so the treatments of the cancer. But in the pink, you see the indirect costs. So for example, if someone stops working, stops producing. So all these costs have increased and continue to increase over the years. And these are the list of out-of-pocket expenses, from transportation to side effect, to medication to control side effects, but also treatments for the disease itself, as well as imaging, pathology. So not just the treatments, the diagnostics, and all the supportive medicines are very often out of pocket. So when we speak about disparities of access, we're not talking about just expensive medicines, but also radiotherapy, pathology, and also what we call supportive medicines to control the symptoms and the side effects of the most important one, control of pain. And the map that you see there on the bottom is the map of the use of morphine in the world. There are countries with excessive use, and there are countries where patients still die in pain. So all of this has led to a huge impact on the financial security of this disease. And so this is fundamental that we continue to fight against this. A few last points. Access to clinical trials is also very unequal and also very low. You can see there that even in high-income countries like Korea, less than 10% of cancer patients actually go into clinical trials. And this is something we need to continue to fight for. And finally, goal number 10, which includes the legal rights, including the right to work. And so we have done, and I don't have the time to show you, but a map of the world where there are laws protecting cancer patients, or in particularly advanced cancer patients, against discrimination, protecting at work, and also providing some social protection. But what we have seen is that more than 70% of patients still report that the disease has a negative impact in their work and in their career. And not everywhere there are legal protection at work and also for social and financial support, not just for the patient, but also for the caregivers. And you can see here our research showing that on your left, you see the negative impact on the ability to work is over 70%. Now, there are some work going on discussing if we should, for example, characterize metastatic or advanced breast cancer as a disability and provide to these patients the support and the protection of disabled people that have other diseases, more like a chronic disease. And we are fighting for that and understanding if in each country that's the best way to go. And what I advise you is for you to discuss internally in Korea if that would be the best approach for people living with metastatic disease, have access to more social protection, more financial protection, and protection also at work. So all this work has led to the new charter, and these are the new 10 goals. And they all have the same topic, but with a little bit of change in the wording. And these are the goals that we will keep fighting for in this decade, 2025 to 2035. And what I would ask you is for you to understand that this charter is a powerful tool to advocate, to lobby, to pressure for the rights of patients living with advanced breast cancer. So take it. It can be translated. Just contact the ABC Global Alliance. We can translate it together with you. You can use in your country to give to your politicians, to give to those who take decisions. Make your voice heard and fight for your rights. And also collaborate and share experiences with advocates around the world. We can only learn from each other and see what works better. And also join the ABC Global Alliance. There's the link where you can join us. It is free, and you can have access to all our resources and continue this fight together with us. And finally, I just want to thank all the committee that has worked in this report, also the company with whom we have worked, the VML company, and also the staff of the ABC Global Alliance. And please try to join us at the next ABC conference in November 2027 in Lisbon, Portugal. Thank you very much for listening.